Let's turn to video 8, Clinical Tips for Treating Pediatric OCD, Long-Term Follow-Up in Treatment-Resistant OCD. So some tips for those of you who are in the trenches treating pediatric OCD. It's vitally important to involve the family in the assessment and treatment options of pediatric OCD. The family can provide essential information regarding how children may involve other family members in compulsion, how symptoms impact everyday life, making everyone late for school because of morning rituals or limiting activities because of fear of contamination. It may also be very useful to externalize the problem by acknowledging how OCD makes children do things, talking about how OCD, rather than the child, makes everyone late for school, to allow others to discuss symptoms without directly blaming the child. The long-term follow-up of pediatric OCD patients is significant. 40% of pediatric OCD patients continue to suffer from full OCD symptoms into adulthood. 60% continue to suffer from subthreshold OCD symptoms. Anxiety and mood disorders are the most common comorbid conditions at follow-up. An earlier age of onset, increased duration of illness, and inpatient OCD treatment are associated with greater persistence of the disorder. The challenge is this: a third of patients don't respond to any treatment. And of those who do respond, many respond only partially with continued functional impairment. Earlier onset may also be associated with decreased response. For treatment-resistant OCD, Clomipramine may be used as an alternative following 2 failed SSRI trials and augmentation with cognitive behavioral therapy. Augmentation with Clomipramine can significantly increase treatment response, and there are studies that have shown this. Clomipramine use requires detailed personal and family history of heart disease and seizures, physical examination, EKG at baseline, and 1 to 2 weeks following dosage adjustment. Use serum levels of clomipramine and its non-serotonergic metabolite desmethylclomipramine to determine dose adjustments. Remember, clomipramine is a tricyclic antidepressant, and the tricyclic antidepressants in children and adolescents have rarely been associated with significant cardiac arrhythmias and even sudden cardiac death. CBT, ERP augmentation of SSRI treatment, and a clomipramine trial should be completed before attempting treatment augmentation with an antipsychotic. Key points are these: 40% of pediatric OCD patients continue to suffer from full OCD symptoms into adults, while 60% continue to suffer from full or subthreshold OCD symptoms. 1/3 of OCD patients don't respond to any treatment, and of those who do respond, most respond partially with continued functional impairment. Clomipramine can be used as an alternative treatment following 2 failed SSRI trials and augmentation with CBT. Treatment recommendations encourage ERP augmentation of SSRI and clomipramine before augmentation with an antipsychotic.